Hello, everyone. Welcome back again to the Red Wrist School. My name is Rana Patel. I'm the co-director with Dr. Jeff Willey of this online workshop. And I'm also discipline lead within the space radiation element here at NASA Johnson Space Center in the Human Research Program. So we're almost done with our week-long workshop. This is the second to last presentation. It's a workshop with presentations from subject matter experts, content experts, who are discussing human health risks from spaceflight. And in fact, that is the focus of the Red Wrist School, teaching these high priority red risks to human health in space as defined by the HRP, the Human Research Program. We're targeting not just typical academics, but also clinicians, entrepreneurs, anybody really who has expertise with NASA research and also who has no expertise with NASA or spaceflight experience. And most importantly, we want to help you take technologies and ideas and innovative thinking that you might already have into the spaceflight space sector. And so we'll be holding these workshops. This is the first year, the first week. Next year, we're going to have week-long seminar as well. And we are funded through the Translational Research Institute for Space Health. They are similarly want to advance this innovative thinking and even risky approaches to help us successfully explore space. So if you guys have questions, if the attendees or panelists have questions, that's great. There's a Q&A feature within your window. You can click on it, type in your question, and then our speaker will address them. Jeff and I can help address those questions after the presentation. The presentation is going to be recorded. The PDF of the talk will be available online in a couple of days, and we'll contact you guys about how to access them. So with that, I'm really happy to introduce our speaker for the day. It's Captain Tyson Brunstetter. And so I'm going to try and remember all of his degrees. He's an OD, he has an MS, he has a PhD, and he has an executive MBA. So he doesn't eat or sleep. Well, actually he does now because he is done with schooling. And he's going to talk about the risk of spaceflight associated neuro-ocular syndrome. So with that, I will let him take over.
Thank you very much, Drs. Patel and Willie. It's such an honor to be here. I appreciate the opportunity to talk to the TRISH folks through the Red Wrist School. Let me grab the screen, and I will show the presentation. Does everyone see that at this point?
No, we don't see it.
Are you sharing your screen?
I think down at the bottom to click share screen.
Here we go. There we go. That should work. Sorry, my first time to Zoom. Okay. All right. Well, thank you so much for allowing me to be here. Unfortunately, Dr. Tarver, who is the guru of VIP SANS, is not able to join us. He is actually on console in mission control as we speak. So he's unable to join us. So I'll do my very best to present on behalf of both of us. As was mentioned, I'm actually a Navy officer who is incredibly lucky enough to be stationed here at JSC for 3 years. And the big portion of my responsibilities are to work in this SANS arena, this spaceflight associated neuro-ocular syndrome, to look into what is causing this, how can we mitigate it, because it's been around a long time, and we realize that this is one of those red risks that we need to deal with before we take any missions to Mars. So with that, I'd like to present kind of an introduction to SANS, as well as some of the clinical insights, and then bring up some questions of interest that you might like to hear about. So before I go further, like I said, I haven't been here all that long. I've been here 18 months, and I need absolutely to acknowledge all the folks who've been working on this for years, especially the folks written on this slide. Dr. Tarver, who's the SANS clinical lead. I'm his deputy. as well as Mike Stenger, who is the SANS research lead. But we have a huge team that we all work together, both here at JAC, but outside of the walls here as well. So this is not all me. I'm just representing this great team. So let's go into this. What is so special about the eye, and why is it important in spaceflight? So just to kind of put this in context, the eyeball is only about 1 inch in diameter. That's quite a bit smaller than most people realize, and yet it provides about 80% of our total sensory input into our body. And that's one of the reasons why a medical emergency is defined as life, limb, or eyesight. We need to be very, very concerned about all three of those. The eye presents a tremendous amount of health information. If we talk about a neurological state, it's interesting to note, let me grab my laser pointer here. It's interesting to note that 1/3 of the 12 cranial nerves can be evaluated by simply looking at the eye or looking at visual performance. So here we see eye position. That doesn't look right. We look here, lid position. The left eyelid is lower than the right. And pupil size and its reaction gives us a lot of information about the neurological side of things, looking at those cranial nerves. Over here on the right-hand side, we have a schematic of the visual pathway going from the front of the eye, the cornea, all the way back to the visual cortex at the very back of the head. And if we take a look at the visual sensitivity of the eye over an area, say 60 degrees total diameter around central fixation, if we see decreases in that visual function, many times we will see a very specific pattern depending on where the pathology is occurring. And you can see examples of these here. For example, if we have, say, a pituitary adenoma tumor growing right about here, what we will see is a loss of visual function in both eyes on the outside. When we see that, we can pinpoint with great accuracy where that lesion or that issue is occurring. So through these neurological evaluations, we can very quickly diagnose or at least give an indication of a potential tumor or an aneurysm or a potential stroke that has occurred. Now, we can also get a very good idea about the presence or severity of systemic disease. So if we look over here on the right-hand side, this is just a gorgeous photo of the back of the eye that we look at with an ophthalmoscope or something similar. This is a normal view of the back of the eye in a patient. Where this general pink area is the retina, this disc is the optic nerve head, or we also call it the optic disc because of that disc appearance. So you'll hear me say either optic nerve head or optic disc. It's really tomato, it's the same thing. We also look at the blood vessels, and the macula is this little darker area here you see with this laser pointer. That is our central vision. That's what we use to look at objects and see in great detail. But as we look back in there, we can get a strong indication of systemic issues occurring. For example, high blood pressure, diabetes, impending stroke, or a high intracranial pressure, or even hyperthyroidism. So if we look over on the right-hand side, right here, it could be an indication of high blood pressure or more likely diabetes in a patient. We see hemorrhages. We see areas of small areas where the blood flow has been reduced. Over here, just above the blue arrow, we see a little bit of debris in the bifurcation of a blood vessel. If I see that in the back of an eye, that indicates to me that probably there is a plaque buildup at the bifurcation of the carotid artery as it comes up the neck and becomes the internal and external carotid. If a little bit breaks off of that debris, it can flow up, go into the first branch off of the internal carotid, which is the ophthalmic artery, and go into the eye. And we can see something lodged in there like this. That indicates that we need to get that looked at with Doppler ultrasound to ensure that those bits of debris don't break off and pass by the ophthalmic artery and go up into the brain and produce the definition of a stroke. So lots of information, and because of that, the eye has been called the window to the soul. And therefore, astronaut eyes, for these various reasons, have been always evaluated pre-flight and post-flight by NASA since the earliest days of spaceflight. And luckily, we're including in-flight testing as well at this point in time. And I'm also realizing that I don't see the Zoom screen, so if questions pop up, just interrupt me. So let's dig in a little bit deeper about the eye, and specifically about the optic nerve head or optic disc, and the retina. They are part of the central nervous system. If you look at this view on the right-hand side, this was just a simple Google search for central nervous system. And this is what you get. You can see the brain and the spinal cord and the cranial nerves coming out. And you can see the optic nerves coming forward, but then they kind of stop. Well, the reality is that the retina, the optic nerve head, and the optic nerve are part of the central nervous system. They fall also behind the blood-brain barrier, and just like the central nervous system, just like, let's say, spinal cord trauma, they are susceptible to permanent loss. Now, if we blow that up, you can see the drawing here on the side. We have the optic nerve coming in from the back, from the brain to the eye. We also have the optic disc or optic nerve head. And then the pink, the reddish area here is the retina itself. All three of these are interconnected. They're actually one and the same for the most part. We'll talk about that in a minute. So the optic nerve head, as I mentioned, connects the eye to the brain. It is bathed in cerebrospinal fluid in the subarachnoid space immediately around it. The optic nerve head or optic disc is right here. It's where the optic nerve actually meets the eye. And because of its position, it has an intracranial pressure behind it. But on the other side, inside the eye, it has an intraocular pressure. So it's got a pressure gradient in between, it sits right between that pressure gradient, intracranial pressure, intraocular pressure. And that may potentially be something that we need to consider as we talk about SANS. The retina is the very back of the eye, that pink that we see here. Its job is to convert light energy into neurosignals. So those signals originate in the retina, and then they are transmitted through nerve fibers that exit the eye through the optic nerve head or disc, and then transmit through the optic nerve back to the brain. In the occipital cortex of the brain, those neurological signals are put together, and that is where we get our perception of vision. The retina has an extremely high metabolic rate, very, very high demands. It has very, very low reserves. For example, if you take a look at the mitochondria within the photoreceptors, they operate extremely high at about 70 to 80% of their total capacity. And because of that, they require a highly reliable, very well sustained blood supply, because they need a constant supply of oxygen as well as glucose, et cetera, to function normally. In the bottom, what you see on the left is, again, as we've seen before, kind of a photograph of a normal retina. You can see the optic disc there. This yellow line runs, its origin is right here, and it runs towards the right, and it runs through the macula. if you take a look at the black and white, it looks like a cross-sectional photo. That's exactly what it is. We have a cross-sectional photo of the front of the retina here, and we see the retina within that, and then the back of the retina is here. Immediately behind that is what I call the cloud layer. That's called the choroid. That is an extremely dense network of blood vessels. The job of the choroid is to supply the blood supply, the oxygen supply, etc., to the backside of the retina, actually to the photoreceptors themselves that actually lay right here on the posterior side of the retina. So this yellow line actually corresponds to the cross section that you see here. And the way that we get that cross-sectional image is through a device called the optical coherence tomography device, or OCT. We'll talk about OCT quite a bit here today. And you can see the OCT image being captured on board the ISS, the International Space Station. And we do this routinely, typically 3 times per every 6-month tour up on the ISS. It requires, obviously, a subject, so that we can scan the back of that person's eye, as well as an astronaut acting as the operator to operate the controls to capture scans like this. The way I describe OCT is it's sort of a very small version of an MRI. You can take slices, cross-sectional slices of the retina over areas, and then combine those to see areas, volumes of the retina itself. It's truly amazing. The resolution is down to individual microns, and it's totally non-invasive as well. So it gives us incredible detail about the back of the eye in such a way that we can look at, say, expansion of the choroid or expansion of the nerve fiber layer, which runs here towards the top of the retina itself, heading towards the optic nerve, where those fibers exit into the optic nerve and then on to the brain itself. So let's talk about some SANS clinical findings and what is SANS? What is that clinical definition? So here we have a histogram. Just to give a little background here, these are USOS individuals, and what that means is it's a fancy term for astronauts who are from the United States, from Europe, from Canada, and from Japan. It does not yet include cosmonauts from Russia. So basically, USOS at this point in time stands for all astronauts, not including Russian cosmonauts. So we're looking with these folks, individuals with SANS findings, and this includes expeditions 1 through 52. We're currently on expedition 55, so this is just a few expeditions back, which covers, I think, 2017. If you look, the orange indicates a SANS sign that has occurred. The blue indicates whether the number of astronauts who have actually been tested for this particular sign. So over here, and we'll run through these, but the first one here is disc edema. So for example, out of 68 individuals tested, 10 have actually shown that sign. And you can see 68 being the denominator for a number of these, but then we have 52. The reason why those numbers are different is simply based on the device used to test that and when it was first used. And so we have always, for International Space Station astronauts, we've always looked at the back of the eye, and so all of those 68 have been tested, whereas newer technology like OCT and ocular ultrasound has not been tested to the same over the same period of time, and so the denominator is less. I want to also note that there are several signs of SANS that are not included in this, and we won't get into these today, but we are looking at those data, and we just don't feel comfortable really talking about those yet because we need to look at the delta. We need to look and see the optic nerve sheath, what the delta is pre-flight to post-flight before we really want to dig into those details. So let's jump into disc edema. So if you look on the left-hand side of the screen, you see a pre-flight photo of the optic nerve. If you know what you're looking at, you'll notice that this looks normal, looks fine. If you don't know, you might have to trust me on that. But I guarantee you'll notice the difference between pre-flight to post-flight if you take a close look. So here is pre-flight. Here is post-flight. It's the same scale. What you should notice is that the outside, the margin between the optic disc and the retina itself, it's a little bit hazy. It's a little bit blurred. Let me go back. So there's the original, and you'll see that the size gets bigger and that edge of the margin gets blurred as I go from pre-flight here to post-flight here. And we'll talk about this. And if you imagine, I know this is a two-dimensional photo, it's not three-dimensional, but if you imagine, it's as if that retina is moving towards you. And that's exactly what's happening because of the disc edema. It's a swelling within the optic nerve. Let's talk about that. What is edema? Well, bottom line, it's accumulation of excess fluid. It can occur anywhere in your body. It's a swelling. So if you twist your ankle, going for a jog or playing tennis, because of that abnormal condition, you will have edema that occurs, that swelling that occurs. Edema always indicates an underlying abnormal condition that's occurring. Edema doesn't happen all by itself. It indicates an abnormal condition. So terrestrially, if we talk about optic disc edema, if we talk about only occurring in one eye, typically it's due to an optic neuropathy or neuritis, inflammation, or it could be an occlusion of a retinal blood vessel, and in some cases, it could be associated with extreme high blood pressure. If it happens in both eyes, in the optic nerve heads of both eyes, it typically indicates an increase in intracranial pressure. And that would be an example of idiopathic intracranial hypertension, or IIH. IIH has been the classic terrestrial analog for SANS to kind of help the way that people think about SANS. It sort of looks like SANS. They both have optic disc edema, and at least initially it seemed like it was a good kind of go by, a good reference to use to tailor the way we think about SANS. We'll get into that a little bit more in a few minutes. With IIH, or increased intracranial pressure, it typically causes symptoms. So in IIH, by far the biggest symptom that occurs is severe headaches. And also you can have transient visual loss, you can have double vision. Your blind spot, if you test the visual field, it can be enlarged, as well as you can have some changes to your color vision. What we're concerned about overall, terrestrially or on orbit or going to Mars, is that if you've got edema in your central nervous system, including the retina or optic nerve, those neurons can atrophy. They can die because of that and be lost permanently. And it depends on the severity of that edema, as well as the length of time that edema is around, the duration. So severity and duration are the two main things that you need to think about when it comes to edema in the central nervous system, edema in the retina, edema in the optic disc, optic nerve. So the good news from a NASA standpoint is, so far, we've seen no obvious loss of ocular nerve tissue in our astronauts. So thank you for that. That's great news. If we take a look at the right image here, this is an actual fundoscopic or retinal photo image of an optic nerve head in the right eye after a crew member, an astronaut, has returned. They've been returned for 10 days, or R+10. The arrows here indicate a C-shaped halo of edema. And we'll talk about exactly what that means from a grading scale. But at this point, just know that that is a quote-unquote grade 1 edema in this crew member. So because of that, he or she was diagnosed with having SANS. This is fundoscopic images of the optic disc of a crew member. The top ones here, OD means right eye, OS means left. OS stands for ocular sinister, so your left eye is your quote-unquote evil eye, so OS. So you can see right eye, left eye pre-flight in this crew member, and these are fairly old photos, not the best resolution, but you can see that they look fairly normal, no issues there. Post-flight in the same crew member, right eye, left eye, you can see, and this is that example I showed a couple slides back. You can see the edema from pre-flight to post-flight right eye, pre-flight to post-flight left eye. The right eye, you can see that the edema goes all the way around 360 degrees, and even it's severe enough to start kind of obscuring your view of the retinal blood vessels coming into the eye. So that, by definition, is a grade 3 optic disc edema state for the right eye. If you look at the left eye, looking through here, the margin looks fairly clear, but you can see that there is a blurring of the margins that falls somewhere between 270 degrees, but less than 360 degrees. That, by definition, is a grade 1 level of optic disc edema. So let's move on to the SANS case definition. So the diagnosis currently is based solely on a optic disc edema of a grade level of 1 or more, and we call it the Prism grading scale. That is the terrestrial clinical standard for evaluating the optic nerve head for disc edema in cases of increased intracranial pressure. So that just makes sense to apply that to SANS because it at least appears to be a kind of a similar situation. So in other words, because it is grade 1 or above, that means by definition that the edema extends at least 270 degrees around the optic nerve head, and that is as evaluated by retinal photography, or what we call fundoscopy. So you can see here's a normal optic or a fundoscopic view here that you might get from an astronaut on board the space station. So in this case, we have a photo of Peggy Whitson doing fundoscopy on herself, which they routinely do, and capturing images very similar to the one you see over here on the left. That is not Peggy's image, but gives you an idea. So take-home message here is, in order to be diagnosed with SANS, you have to have optic disc edema of at least grade 1 as evaluated by fundoscopy, okay, period. So here we have various levels of optic disc edema going from 0 all the way up to grade 5. How do astronauts fall out in all of this? Well, SANS cases luckily only go from grade 0 up to grade 3. We only have one case that was graded as a 3. That's great news. So the great majority of astronauts fall within grade 0 to grade 1. We have had no astronauts that have been graded as a 4 or 5, which that's great news. So let's talk about this. We mentioned before that to be graded as a grading of 1, you have to have optic disc edema of falling at least 270 degrees but not quite 360 degrees. So that's a grade 1. A grade 2 just means that your disc edema goes 360 degrees around the optic nerve head. It's gone all the way around. Grade 3 is just a worse version of grade 2. 4 is worse than 3. 5 is worse than 4. That brings us back to grade 0. So you might be tempted to think that a grade 0 means that there's no disc edema whatsoever. That would not be true, because if you have 269 degrees of optic disc edema here, that does not meet the criterion of grade 1. And so that person would actually be graded as a 0. So that being said, you can have some optic disc edema, which, remember what I said, that's always associated with some type of pathology, indicates some issue going on. You can still be rated as a grade 0. That's important to realize. So this current definition has some limitations. Number 1, it ignores other signs of SANS. So it's only based on optic disc edema. That's evaluated via fundoscopy, grade of 1 or higher. It doesn't consider any other issues like globe flattening and things that we'll talk about in a minute. It also ignores other diagnostic technology, for example, OCT. OCT technology is objective. It doesn't matter what kind of grader is being used to look at that image. If you take a fundoscopic view of the optic nerve head and show it to 10 experts, you will, and we know this, you will get slightly different answers that could fall over a range. With OCT, it's more objective, and so that subjective nature doesn't come in as much in play. So that being said, the current definition is more subjective than it probably should be, and also it's binary. At this point in time, you're either diagnosed with SANS or you're not. There's nothing in between. So let's take a look at an example. These are 2 fundoscopic images of a crew member. The one on the left is pre-flight. The one on the right is either in-flight or post-flight. I can't recall at this moment. But what you should take away is pre-flight, of course, looks pretty clear, looks pretty good. But the post-flight or in-flight here, you can see this haziness that is in this area. The issue here is it goes quite a fair amount of the way around the optic nerve. Doesn't go quite all the way, and in fact, it's less than 270 degrees. So although from a clinical perspective, if I were to see this in an exam lane, I would be worried about it and I would investigate it. Well, according to the SANS definition, this would be a 0, and this patient, this crew member, would not be diagnosed with SANS. So let's move on and talk about some other signs. Cotton wool spots. A certain number of our folks, 7 out of 68, have been diagnosed with cotton wool spots. What those indicate are they're infarcts, they're kind of a loss of blood flow in a very local area. And through that, in layman's terms, a nerve fiber cell has popped. And the cytoplasm has kind of leaked out, and it gives the appearance of cotton wool. You can see an example of that in the photo. The other one I want to highlight here are choroidal folds. If you look closely here, you can see these sort of horizontal lines that are in the retina. Those are not normal. Those are actual folds in the choroid. We'll talk about that in a minute. So choroidal folds, we'll jump right in. These are just black and white images to give better contrast for you to see. You can see these horizontal lines. These are post-flight in a crew member coming outward here in the right eye, and you can see them moving horizontally in the left eye. And if you look closely here, you can see a lot of those folds actually go right through the central vision of this crew member. So what is this? Well, with SANS, what we see is we can have a thickening of the choroid. Again, the choroid is that dense vascular bed that sits immediately under the retina, and its job is to feed the especially the photoreceptors in the very backside of the retina. What we find is in the great majority of folks, if not everyone, there is a general thickening of the choroid, either focally or generally in these crew members because of vessel engorgement. And because of this engorgement, it puts a little bit of pressure on the back of the retina and can induce these choroidal folds. If we take a look at an OCT image, again, that's a cross-sectional image through the retina going down to the choroid. Here is pre-flight for a crew member. Just for orientation, we have this little dip here. That is the very central area of the macula, your central vision. This is the center of the center. And then we have the retina here, these various different grayscale lines going down into the choroid, that vascular bed underneath that very, very bright white line there. So this is pre-flight, and you can see everything looks fairly smooth. If you look post-flight in that same exact crew member, which just happens to be the right eye here that you see here, this is one and the same. You can see this jagged edge has formed because of the engorgement of the choroid. And in this case, it is severe enough that it actually pushes up and creates retinal folds above it. So typically, but not always, in SANS, these lines run horizontally. They can resolve post-flight, or in some cases, they can persist for 12 plus years. So far, we don't believe that there's a significant impact on best corrected visual acuity, even though it's severe. In this case, this is the worst case we've seen, and it falls right under your central vision. If you talk to eye care providers and show them this image, they would guess that this person is probably around 20/40, 20/50, maybe even 20/60 visual acuity, up to 3 times worse than quote unquote normal 20/20 vision. In this case, this patient or this crew member was 20/20 best corrected visual acuity here. That being said, if these jagged edges were just moved just microns, it's possible that this crew member's visual acuity could have dropped to 20/30, 40, 20/50, 20/60 or so. But luckily, up to this point, we have not seen any significant impact in best corrected visual acuity being anything worse than 20/20. They have all been 20/20 or better. From a terrestrial standpoint, choroidal folds are always associated with some type of pressure, something pushing on the back of the choroid. They could be tumors or inflammation, or it could be IIH. Let's move on. Let's talk about globe flattening and refractive error shifts. For the most part, they're tightly connected. So first of all, globe flattening, right off the bat, it can resolve post-flight or it can persist for 7+ years. We're continuing to monitor it, and it can stay there for quite a long period of time. Let's have a case example here. In the picture, this represents a male crew member who was in his mid-40s at the time of flight. No significant patient or family medical history, no meds. Everything is normal, and in fact, this crew member is what I would call highly athletic, and so this would not be a person that you would just expect to have any problems whatsoever during spaceflight. We have an MRI scan of this crew member pre-flight, and you can see the back of the eye is fairly round. Looks pretty good to me. If we put a yellow line just to kind of generally highlight that area, that's what we have. Now let's look 6 days post-flight. If you look, if you look at the back of the eye there, it does look a little flatter. Let's put in that yellow line that we had here just a few minutes ago. And that really highlights the amount of flattening that has occurred. Does it get better? Let's look at it a year post-flight. And there it is. You can still see some general flattening there, but by my eyes, it looks a little bit better. If we put in that pre-flight yellow line, excuse me, you'll see that, yes, in fact, it has gotten better, but there is still some flattening there. Terrestrially, what's globe flattening associated with? Typically, it's in cases of increased intracranial pressure, for example, IIH. And it's almost always in about 94% of cases, 96% of cases, it's bilateral, it's in both eyes. Keep that in mind, both eyes. We'll come back to that in a minute. Let's move over to hyperopic shifts, or shifts in refractive error. So if you look at post-flight questionnaires for crew members between 1989 and 2011, about a quarter of short duration, in other words, shuttle astronauts, and about half of long duration, or ISS mission astronauts, report a degradation in their vision, especially up close at near distances. Because of this, this shift in refractive error, mostly due to the globe flattening, the astronauts are provided quote-unquote space anticipation glasses. And all that means is that Dr. Bob Gibson down in the clinic will get a rough idea of what kind of globe flattening could potentially occur in this crew member, and then gives a number of eyeglasses to that astronaut before they fly to hand carry those up with him or her. And then as the vision changes, if it changes, they're able to put on different glasses to hopefully correct that. So like I said, hyperopic shifts or refractive error shifts are mostly attributable to globe flattening. And we've seen pre to post flight changes that are up to plus 1.75 diopters. That's quite significant, very, very significant. Like globe flattening, you can have rebounds when you come back to Earth, or this can persist for, again, 7+ years. The clock is still ticking on this. Like I mentioned before, we've had no loss in best corrected visual acuity, that is 20/20 or better in all cases. Let's talk about common characteristics of the cases. So almost all were long duration ISS mission crew members as compared to short duration on space shuttle. I believe we've only seen, and this is a retrospective study looking back at space shuttle, with scrutiny looking back at all those fundoscopic images. I believe there's only been one short duration crew member, and that's typically 14 days of a mission, who was diagnosed with SANS. Everyone else has been long duration. So that brings up the question, is the severity of SANS related to duration of spaceflight? This might indicate that it is. And if that's the truth, then we should really be concerned about a 3-year Mars mission as compared to a 2-week shuttle mission, as compared to a 6-month or maybe even a 12-month ISS mission. All these folks are basically healthy individuals. They've got normal medical history, normal pre-flight eye exams, and they're negative for uncontrolled systemic disease. These are people you would not expect pathology to occur in. The ISS cabin, well, what we do know is historically there's been an elevated level of carbon dioxide, and currently it's about 8 to 10 times the terrestrial levels that we experience sitting here during this presentation. And we do know that CO2 is a potent vasodilator, and there is some potential that it does contribute to SANS. One thing to keep in mind is the CO2 levels have gotten better. I'm not sure how I should do this on the screen to make it the right x-axis, but the CO2 levels have reduced over the years on board the ISS, and a lot of that is due to the flight docs kind of pushing the medical side consequences of high levels of CO2. But we're still seeing SANS. So none have experienced loss in visual performance to the best of our knowledge, and that includes best corrected visual acuity, color vision pre-flight to post-flight, and then depth perception pre-flight to post-flight. And this is one of the keys here. None have complained of the classic symptoms of IIH. The biggest one would be severe headaches. That just does not occur. Now, crew members may have lesser forms of headaches, but it is believed that that would be associated with the initial congestion as well as potentially the level of CO2 that they're experiencing. That has not been associated with SANS. Let's talk about some recent findings that kind of put a really big spin on things. So you may have written a note about 10 out of 68 crew members, USOS, on board the ISS have been diagnosed with SANS. Well, that's true if you use the strict definition of SANS. But let's talk about this now. Optic disc changes with long duration space flight. Well, there have been a number of folks, including Dr. Brown, who is a retinal specialist who serves on the SANS Research and Clinical Advisory Panel, or RCAP, as well as Nimish Patel. He's a OD PhD who analyzes with great scrutiny all of the, excuse me, one of the negatives of sitting in your office. And Nimish Patel, who he is the person that looks at all the OCT images of all the crew members, as well as our folks across the street here at JSC, the researchers looking at SANS and fluid shift studies, etc. Well, what Dr. Brown found that he showed about a year ago, he analyzed 14 crew members having complete pre-flight and on-orbit OCT data. Every single one of those 14 crew members, every one of them showed signs of thickening of the choroid, venous engorgement, but here's the big item, optic disc edema. Every single one of them showed some level of thickening of the optic nerve, as well as kind of a spilling out of that into the nerve fiber layer going into the retina. Another thing that has been noticed by these folks is in the optic discs, they tend to not only expand forward, but they actually extend backwards towards the brain as well. And what's interesting is that backward movement is opposite to what typically happens in IIH. In IIH, you have a physical pressure coming from the brain pushing towards the back of the eye. And you can imagine with that force pushing forward that the optic nerve head would actually move forward as well, kind of in a unit, as well as with edema pushing the front forward even more. That's not exactly what typically happens in SANS. It's different. So here we have an example. This is just a black and white image from an OCT, just kind of almost a fundoscopic image. And this yellow line is that cross-sectional scan that's been taken, and you can see that cross-section here. And again, it shows the retina, and then right about here, it represents the optic nerve. Every optic nerve has a cup. It's just an empty volume there. It's an empty space. Everybody has some level of cupping. Some have bigger cups and some have smaller ones, but we typically have something there. And then over here is the retina on the opposite side of the optic nerve head. You can see that cloud layer, which is the choroid. And so let's talk about that. I've made this is a pre-flight image. Here's a yellow line indicating the outside or the top side of the retina. I made a red line here to indicate the back side of the choroid, the vascular bed. Let's move on to in-flight. And you maybe you saw some bouncing there in the images. Let's put those lines back. What you should notice is there is some increased thickness here as well as through here in the optic nerve head. So that would fall right around in here. Then if you look here at the red line, you can see some of that cloud layer, the choroid popping through towards the back. That means there's a choroidal engorgement occurring there. It's interesting, but it becomes extra interesting when you realize that this is a non-SANS case, but it was noted in the record, and that was based on OCT imagery, that this was considered a subclinical edema case. So when you go back to that histogram, 10 out of 68 crew members, well, this was not one of those 10. This is in addition to that. Next question might be, well, does it get better when you come back? Well, let's take a look, and you can see that for the most part, there might be a little edema left over. I forget how many days return this is, but for the most part, in this patient, at least this crew member, looks like it went back. So that's good news. Why is this happening? I'm not going to spend a lot of time on this because the bottom line here is we don't truly know. And we're hoping that the people online here and the people that look at this video later on, maybe this will help spark some thought and for you to create your own theories or to bolster some of the theories I'm about to talk about. What we do know is that in space, you go into microgravity, 0 G's essentially up on the ISS. What this does is it allows your fluid within your body to redistribute, and what happens is you have about 1 liter to 2 liters of fluid that move from your feet up towards your head. So keep that in mind this Saturday night when you order that Domino's pizza and the 2 liter of Coke, that 1 to 2 liters is flowing up towards your head. Something's got to give. Something's going to happen with all that fluid moving up towards your head. And because of that, we do know that there is cerebral venous congestion. The veins will enlarge, they'll overfill, they'll distend. Does that mean that the flow, the velocity is slower? What happens in the choroid? You've got your veins in there as well. Does that slow down the movement of blood and therefore change metabolism, reduce the physiology in that area? We actually don't know. But let's throw in some twists here. There are confounding variables. If you do restrictive exercise, that increases, it's almost like a Valsalva, and increases the blood pressure in the head. That may not be good. We don't know. We don't know. In other ways, it's very good. It helps with your bone density, etc. So we need to find out what is the best balance here. Does it have any impact whatsoever on SANS? We don't know. Sodium intake is another thing. Historically, back in the day, astronaut food throughout the day could have been as high as 5,000 milligrams of sodium. That's a lot. Now, since then, it's gone down substantially, but we honestly don't know how much they, quote unquote, sprinkle salt on their food. Can't sprinkle in space, but you get the drift. Then there's CO2 levels being 8 to 10 times the levels on the ground. And the pharmaceuticals, we don't think that anyone's taking any pharmaceuticals up there that would affect intracranial pressure, for example, but we can't rule it out. So SANS comes about definitely from microgravity. It's part of the name, spaceflight. But from there, we don't know. Is it due just simply the fluid shift, venous congestion, or these confounding variables? And so there are 3 main hypotheses that have been generated over the years. The first one, and kind of the primary and kind of the original theory, is that there's an increased intracranial pressure that is causing some type of imbalance between intracranial pressure in your head and intraocular pressure within your eye. It's a pressure gradient that, oh, by the way, is focused right on the optic nerve head. It makes sense that that could be true. Now, there are 2 kind of subset theories here, in that it could be an overall increase in intracranial pressure, and it's putting pressure on the back of the eyes, and that typically would be bilateral. But it could also be localized to one eye, because if you look at the general signs of SANS, historically, it looks like there might be a right-sized bias. For the most part, not always, but for the most part, in the right eye. Seems to be worse than your left eye. We need to look more into that, but if that's true, then it doesn't completely support the idea that the intracranial pressure globally increases, because typically that pushes on both eyes more or less equally. So what if it's localized to one eye or the other? And so if you consider that the optic nerve is bathed in cerebrospinal fluid within the subarachnoid space, the subarachnoid space has a lot of compartments. It's got a lot of dense tissue that is more or less randomly oriented, and they could create compartments or septations that, if conditions are just right, it could be that the cerebrospinal fluid is able to enter through that space, but for whatever reason, it could be a one-way valve and that the pressure is not able to get out. So it's possible that there could be a local increase in intracranial pressure immediately behind one eye that might be worse in one eye versus the other. We don't know. Hypothesis 2, in my opinion, is a little more simple because it could be based on the simple venous congestion. If that congestion occurs, like I mentioned before, does that slow the outflow of the blood outside of the head return to the heart? And because of that, could that reduce physiology or the metabolic rate in the retina or the optic nerve? It's possible. It's also possible that that engorgement of the vessels could place direct pressure on the retinal axons or the optic nerve or optic nerve head directly. Other hypotheses include individual anatomical or genetic factors, for example, the altered one-carbon metabolism theory. And again, that's certainly possible, and it deserves attention. Let's go into SANS questions of interest, and let's see, how are we doing on time? We're okay? Okay. So let's just jump into these questions. So is SANS a male-only syndrome? You may have heard this in the past. It's a very popular thing to say, that this is male-only. Well, the answer is no, period. It's true, only men have been, quote unquote, officially diagnosed with SANS. But keep in mind, number one, only 11 USOS women have flown in expeditions 1 through 53. So by my limited brain capacity, that is a tiny N, that's a tiny sample size. That being said, female long-duration crew members definitely have shown ocular changes. That includes some level of optic disc edema of some amount. They've shown thickened choroid behind the retina. They have shown globe flattening, and with that, refractive error shifts. So for me, better questions might be, is SANS prevalence equal between males and females? But is it being masked simply because there is a small female sample size? If the prevalence is not equal, are females less severely affected by SANS than males? These are critical questions that need to be answered. It certainly could be that females are less severely affected. We just don't know. But if that's true, the next question is why? Is SANS less prevalent in space-naive astronauts? Space-naive meaning that repeat flyers we'll call those veterans. Space-naive astronauts are those who have never flown before but are flying now. So let's look at that. The answer is probably not. So we've created a histogram showing the prevalence of these findings in space-naive individuals. So in other words, this is, they're being compared pre-flight to in-flight / post-flight to look for changes. So these are the numbers. Now, I don't expect you to remember what the overall numbers were for everyone as a group, so I've listed them. Keep in mind that the space-naive individuals, the total is only 18. So we have to take this with a grain of salt because subject numbers are small. But if we compare space-naive here in this column to all crew, which also includes space-naive, if you look at the various different SANS signs that we have running along the bottom here, the percentages are roughly identical or very close, especially if you take that grain of salt into account. So the answer is probably not. But that being said, if actually we're going to get to that, I will stop right there. Is IIH an adequate terrestrial analog for SANS? IIH is the classic terrestrial analog for SANS. Is it adequate? Probably not. Let's talk about why. We're going to run through all these various signs and symptoms and compare the typical IIH with the typical SANS. Now, every condition you talk about will have some variation, so I'm talking typically, not absolute. So optic nerve head or disc edema, yes, they both have it. IIH and SANS, they both have disc edema, and that's why originally the two of them were compared very, very closely. Intracranial pressure, yes, IIH by definition has increased intracranial pressure. From a SANS perspective, it's to be determined. It's inconclusive evidence at this point in time. If you look at some data, it might actually suggest that intracranial pressure reduces in flight, but we don't know. That's one of the areas where we need to have that information. There will be an upcoming research initiative that will do direct ICP measurements, lumbar punctures, pre-flight and very, very quickly after flight, post-flight. That is a great first step. And they'll also compare those results with non-invasive techniques of intracranial measurements. That, by the way, will also be performed in flight. That will provide very, very interesting information. But hopefully someday we will know without a doubt what intracranial does in flight. Males and females, IIH, the ratio is about 9 females per 1 male being diagnosed with IIH. SANS, it's TBD, but like I mentioned before, no females have officially been diagnosed. So technically, officially, it's 0 females to 10 males, but again, we see changes in both sexes. And so if we tinker with the definition of SANS, which is coming up, that ratio will change. But I guarantee it's not 9 females to 1 like it is with IIH. Body mass index, BMI, IIH patients are typically obese, over 90% of those folks. So when you talk to a clinician, they are thinking in their head, okay, it's typically a relatively young obese female is that IIH patient sitting in the chair. It's not the case with SANS. These people are typically quote unquote normal BMI all the way to extremely highly athletic. Symptoms, we mentioned IIH, the classic or chronic severe headaches in 94% of cases. They can also, in about 68% of the cases, have a transient vision changes or obscurations. For SANS, there are no symptoms. The astronauts are not complaining about visual complaints or symptoms, except for the fact that their near vision can change based on those globe flattening and refractive error shifts. Side bias, I mentioned this before. IIH in less than 4% of cases is it unilateral, is it only in one eye. For SANS, it's technically TBD, but the gross signs overall have suggested that it is right-hand biased. So again, very, very different between IIH and SANS. Optic nerve head displacement. In IIH, there is a gross movement forward in general of the optic nerve head. In SANS, you can see on the photo on the right, if you remember, we talked about the expansion that is forward at the top and backwards towards the bottom of the optic nerve. That is different than the typical view of IIH. So very interesting. It suggests a different mechanism where SANS edema may appear to originate in the middle of the optic nerve rather than originating kind of towards the back. Something to look into. So the ratio of retinal folds to choroidal folds in IIH, it's greater than 5 diagnoses of retinal folds to every 1 choroidal fold. And it appears typically that in IIH, retinal folds occur first. If you look at SANS, typically the ratio is the exact opposite. So for every 5 cases of choroidal folds, there's only 1 case of retinal folds. And it appears that the choroidal folds occur first in SANS, and if they're severe enough, they typically will create the retinal folds. Very interesting. So fold pattern, we mentioned this. And again, typically in IIH, the most prevalent versions show a concentric pattern that attempts to go around the optic nerve head. You can see 2 pictures of IIH patients here on the left. If we look at SANS, it's typically a linear pattern, typically, not always. And then let's talk about post-flight MRIs or just MRIs in general. For IIH, the brain typically displaces downward within the skull, and there's typically no change in the size of the lateral ventricles. If you take a look at the great work done by Donna Roberts and her team, looking at the effects of spaceflight on astronaut brain structure on MRI, this was published late last year in the New England Journal of Medicine, again based on NASA data. What she found was that the brain post-flight in these astronauts compared to pre-flight, the brain displaces upward and the lateral ventricles enlarge typically. So I'm going to click this and you can see the bouncing back and forth between pre-flight to post-flight, and you can see this view here where the lateral ventricles appear to expand. Over here you can see a side view of that, as well as the brain itself moving upwards. The idea is, what if that reduces the outflow of cerebral spinal fluid out of the brain, which would then potentially increase intracranial pressure? So something to consider. So bottom line, is IIH an adequate terrestrial analog for SANS? Not so much, and the bottom line is SANS is unique. We do not have a perfect terrestrial analog at this point in time. Is there a way to predict who will be diagnosed with SANS? Not really, but the best we can do at this point in time is to look at repeat offenders. That might give us the best indication. So what I mean by that is, if you have flown in space previously and you were diagnosed with SANS findings, not just edema, but it goes across the board: choroidal folds, globe flattening, refractive air shifts, retinal hemorrhages, et cetera, you are quite likely to develop the same findings during your follow-on long-duration flight, and potentially it could get worse. But again, the sample size is so small that we can't say that with statistics behind it. But one recent finding is that the optic nerve head cup volume may be associated with SANS diagnosis. Let's talk about that. So here what we have are 12 subjects, all crew members, and I put these in order from what I thought was the smallest optic nerve cupping here to the largest here. And again, I showed you that cross-sectional view of an optic nerve cup, and it looked kind of like this. Well, this is just more of a three-dimensional view of that, where it's kind of best illustrated in these larger cup sizes here. Anyway, again, the cup is an empty space that falls within the optic nerve, and it is created simply because the retinal neurons coming out of the retina, they come and they meet in the optic nerve, and then they turn 90 degrees, and then they go out the optic nerve. They create the optic nerve. They create the optic nerve head, and based on the number of axons, neurons, how small or big your optic nerve head, it will give you a cup, just naturally. Some people have small cups, some people have large cups. Well, a question came up here at JSC, well, okay, so we have these three-dimensional photos of the cup volume. Does that have any association to those who have been diagnosed with SANS? So we went back and we looked, and lo and behold, wouldn't you know that if we put red lines underneath the subjects who were diagnosed with SANS, here we go. And it makes you wonder, well, what's different about subject 2 and maybe subject 8? But if you look at it just kind of a 30,000 foot perspective, it looks potentially like the larger your cup volume, the less chance you have of being diagnosed with SANS. We went back and took a little bit closer look at the data, and this is still a work in progress, but we looked back and what we found was that the ones labeled with the yellow lines here, those were labeled as non-cases, non-SANS, but they had quote-unquote subclinical edema. So now it gives a little more justification or rationale that it does appear that the smaller your cup volume, the higher your chances of being diagnosed with SANS. What does that mean? What impact does it have? Well, here, and I have to highlight the incredible work by Myra Nelman and Simon Clement, who both work here. Their ability to process OCT images is second to none worldwide. And so this is something that they have shown. So here's a large optic nerve cup volume, and here's a smaller one. And this one is a case. The one with the big volume is a non-case. So it appears that the optic nerve edema that occurs in SANS, and keep in mind, everybody who goes into space has some level of optic disc edema, we believe. Number one, spaceflight engorges the neurons within the optic nerve head to some extent, and those edematous neurons begin to occupy some of that empty space of the cup. If it occupies enough volume, maybe there's a pressure threshold, then that edema starts to spill out upward above the optic nerve head, and it's at that point that you can visualize that with a fundoscope. You can see the picture there. If you will, the edema is localized within the optic nerve cup, it is extremely difficult to see that with the fundoscope image. It's just not sensitive enough. So, so that would go along with the theory that if you have a large cup volume, that you would be less likely to be diagnosed with SANS. Brings up a couple questions now. So if you have a large optic nerve cup, is that protective against SANS? Should we send up astronauts with large cup volumes? Is that good news? Or does that mean on the flip side that is SANS simply being underdiagnosed because in crew members with large optic nerve cups, because we've been relying on fundoscopic views that are not as sensitive? In other words, are these people with large cup volumes just as susceptible to potential edema-induced vision loss as everyone else? We don't know. So you may be wondering, you may have heard of VIP in the past. You may be wondering why it's called SANS now. Well, in the past it was called VIP, vision impairment intracranial pressure. As Dr. Tarver always says, there are only two problems with that name, and it's vision impairment and intracranial pressure. Those are the two issues with that name. Vision impairment, like I mentioned before, there has been no vision impairment, which, by the way, is defined by NIH as having best corrected visual acuity worse than 20/40 in your best seeing eye. That's not happening in any astronauts. We have not had anyone worse than 20/20 in either eye, best corrected at any point. So therefore, there's no vision impairment. And then intracranial pressure, like I said before, it has not been conclusively tied to astronaut vision issues. We don't want people, researchers or clinicians, to be stuck on that intracranial pressure point. We want it to be expanded, think outside the box, that type of thing. That being said, it could be ICP, but it may not be. We don't want it to be constricted. So we've renamed it Spaceflight Associated Neuro-ocular Syndrome, or SANS. We believe that's more accurate given current evidence, and it's more general, it's more inclusive, and could include a wider range of pathogenesis possibilities. So take-home messages for you here today. The top SANS-related risk is by far optic disc edema. The retina, optic disc, optic nerve is all part of the central nervous system. Therefore, it's susceptible to permanent vision loss. It's permanent vision loss in general, depending on the severity of the edema and the duration. Again, currently, there's no evidence of true vision impairment in any long or short duration astronauts. But that being said, most, if not all, ISS astronauts have ocular changes in flight, and that includes optic disc edema. Because of that, we cannot yet predict the impact of SANS during expeditionary spaceflight, for example, to Mars and back. It's that whole severity over duration. The SANS case definition requires an update, without a doubt, and we're working on that because it's based on two-dimensional photographs from fundoscopy. It's subjective. It's either you have it or you don't. It's binary. There's nothing in between. We believe that it should include objective testing, for example, OCT. In fact, it should be heavily related to objective testing, and it should be measured on a continuous scale like a thermometer. Everybody has some level of optic disc edema, but not everybody will be diagnosed with SANS. So Dr. Tarver always uses this analogy that everybody has a temperature, but not everybody has a fever. So that'll be kind of the idea that we go forward with. So more to come on that. SANS affects female astronauts too. It's not a male-only syndrome. Space-naive astronauts present SANS signs at approximately the same rate as veterans. IIH is an imperfect terrestrial analog for SANS, but is there anything better? Question mark, question mark. Is a large optic nerve head cup volume protective against SANS, or does it simply mask the SANS diagnosis? Small sample sizes and confounding variables hamper and slow down definitive conclusions. That's if we sent up 2,000 astronauts every year, we would have nailed this down many years ago, but that is just not the case, unfortunately. And then finally, I want to say again that OCT technology is and will be critical in diagnosing, tracking, mitigating, and determining SANS pathogenesis. So you can see some of the examples here, and all of these have been put together by Myra and Simon, just incredible views that really are not available, to my knowledge, anywhere else on the planet. So kudos to them, and a big thanks going out to them. So again, I want to thank everyone who is involved in the SANS team, and that goes way, way beyond me. I am just a cog in the wheel, if you will. So with that, I will exit out and...
Oh, hey, don't do that just quite yet, please, Tyson. We have a couple of questions out there. I'll read the first one to you if that helps. Are you able to see it?
Sure.
One of them was, is long-duration spaceflight going to be put on hold until we have a better understanding of the pathophysiology of SANS? And then, what are some initiatives underway to make spaceflight safe for eye health? And I guess I have a follow-on question for that. Is spaceflight unsafe for eye health? Because right now, we don't know, or we don't know what to say.
Okay. Sorry, I was monkeying with my display because my one screen just went blank. So I heard the first question, and that is, will exploration spaceflight, say to Mars, be on hold because of things like SANS? You know, everything has a risk to benefit ratio, and so we're working very, very hard to try to answer a lot of these questions, and especially as more and more objective data comes in, we're getting better and better at answering some of these questions. I cannot definitively answer that question. there's a certain risk to sending people to Mars from an ocular visual standpoint, and that will be a decision made way above our pay grade, and so I can only guess. I think with all the emphasis being placed on this, that we will stay on the timeline, be able to answer it, so that we won't have to postpone it.
Yeah, I agree.
Fingers crossed.
And then she wanted to know, what are measures, if any, currently been taken to try and mitigate onset progression on the ISS?
Okay, mitigation strategies. So, so you hit on an important topic, and that is there are two main parallel efforts being taken: a mitigation strategy, as well as let's try to figure out the pathophysiology of this, the pathogenesis of this. And the reality is there's some systemic issues out there where humans just don't truly know what's going on, but they know how to mitigate it. So what I'm hoping is that one of these paths for SANS is worked out, and if that happens to be the mitigation route, then that's great, and we'll continue to work and try to figure out what's going on. But some of the potential mitigations would be related to that fluid shift due to microgravity. So you could be using negative pressure, lower body negative pressure, and the fluid shift study, which is spearheaded by Mike Stenger across the way, is looking at that. On board the ISS on the Russian side, they've got the chibis that can pull that fluid down. So they are analyzing those data as we speak. So we'll know more about that in the near future. So you can do that. You can use what I call quote unquote weak tourniquets, which an example of that would be bracelets that the Russians currently use. They're pseudo loose fitting tourniquets that go on the top of the legs, and the idea is you slow the movement of blood or fluid shifts coming back up from the legs to kind of try to keep it as low as possible in the head.
Do the U.S. astronauts don't use that?
Not typically to my knowledge. And to be honest, I can't recall if they tried it with the fluid shift study. Okay. But it is an option, and it does make sense. And another potential mitigation is artificial gravity. If you look back on what's the movie, 2001, you've got the big round spacecraft, and that does make sense. There's some drawbacks to that. For example, when you're spinning around and you move your head, well, it works in funky ways depending on how big that radius is or how small it is. You will feel sensations that you don't want to feel, and you get motion sick out of that. So pluses and minuses to all that. How long do the arms have to be for that to work? But certainly artificial gravity, if we could flip a switch, that would probably fix all of our problems.
Yeah, thank you. John has a question. Is there a role, if any, for ultrasound measuring SANS in space that OCT can't?
Yeah, for sure. In fact, that is one of the devices that's used on orbit, pre-flight, on orbit, post-flight. And ultrasound is, as I'm sure you know, very, very unique. You can use it on the eye. You can use it throughout the body. And it's a fantastic tool. So from an ocular standpoint, what we use it for is mainly to look at it's a cross-sectional view of the eye. Wish I could show a picture right now, but the cross-sectional view of the eye. So you can measure the axial length of the eye, the distance from the front of the eye to the back of the eye, and that can be a way, actually our main way, of measuring the amount of global flattening. But ultrasound penetrates through that, and we're able to see the optic nerve, especially the optic nerve sheath, and we can see the physical size of that. So that's one of the things that we're trying to look at. If you have an increased diameter of the optic nerve sheath, that could potentially indicate an increased intracranial pressure, either locally or throughout the whole head. So that is something we need to look at. So your long answer to your question is yes, ultrasound is important and it is currently being used.
Awesome. Jeff, I mean, I have a couple more questions, but Jeff, do you have any questions?
Yeah, actually, I do have a question. You had mentioned that CO2 is...
Are you muted?
Can you hear me? Hey, can you hear me?
Yeah, we can hear you.
All right, great. I'm really intrigued by something that you had mentioned. So CO2 is seems to be a confounding factor in some of these visual issues and some of the anatomic changes, and I believe you mentioned in the choroid. So if increased CO2 in the cabin could contribute to some of these effects, is it possible that simply just breathing pure oxygen for maybe short periods of time on maybe a daily basis may be something potentially to consider as a mitigator?
Great point. Great point. There is, it's possible. There is research being done terrestrially. Steve Laurie, again here at JSC across the street, Dr. Laurie is the PI on one of the PIs on the vapor study, which is a head down tilt study being performed in the NVHAB in Germany. And previously, head down tilt studies, which can mimic, if your head is down here, can mimic the fluid shift from your feet to your head. Historically, it hasn't turned out to be a great terrestrial analog for SANS. However, recently, they have shown with extremely strict head down tilt, meaning you don't get up, you don't tilt your head up to eat or anything of that nature. You are head down strict the whole time for 30 days. They did diagnose a certain number of subjects having optic disc edema. So the good news here is this may turn out to be a reasonable terrestrial model for SANS that we can use. Now, the beauty of NVHAB is it is a building where they can independently adjust the environment. And that's what the vapor study did. They increased the level of CO2 levels in that building so that the people in the head down tilt for those 30 days were breathing that level of CO2. So the question is, for the vapor study, was that level of optic disc edema associated with the higher levels of CO2, or was it due to the head down tilt with the strict head down tilt? And so they're going to go back and do a control group to tease out those details. So to kind of indirectly answer your question, if they do find out that indeed it was due to the CO2 levels, then it might make sense to go down that avenue of can we titrate the amount of CO2 either by using O2 levels or further dropping CO2 on board? Could that help? So yeah, great question.
Yeah, and that's a great question. I had a follow-up question on that for CO2, but it points to the difficulty because right now there is not a good terrestrial model to evaluate this risk. So you can either use your limited N sample with astronauts or look for alternative terrestrial models. And so that's maybe a great challenge to put out to the research community. NVHAB is one potential way to do it, but are there any animal models or cell models or some other way to model this risk where you can then look forward to go forward and evaluate pathophysiology as well as potential countermeasures? To follow on the CO2 thing, though, you mentioned that one of the terrestrial symptoms of the risk was, the continuous headache.
Yes.
So does that mean that it's present all the time, or it comes and goes?
No, and forgive me for Dr. Tarver not being here because he would answer this instantly. To the best of my knowledge, being here for 18 months, a caveat, to the best of my knowledge, the headaches, if they do occur, oftentimes they're mild and they may be associated with a slightly increased level of CO2. Or if they do occur, they can occur early on in spaceflight, where the body is starting to acclimate to it and trying to work with that fluid chip. But I did want to note that there are rodent studies where they actually have rodents where they lift the hind legs up and give basically a head down tilt to them. So there are, that's a potential analog that also needs to be looked at.
Yeah, and maybe Jeff, you can talk about that because he has expertise with hind limb unloading. I don't know if they've actually seen like disc edema in rodents. Maybe Jeff, do you know?
I don't really know.
Okay.
We do. Our focus is more musculoskeletal, but I think that somebody's probably looked at that. I should know that literature better, and I'll probably be doing that later today, is checking that out.
I don't mean to put you on the spot, but I think, as you pointed out, that's a potential animal model that definitely the research community should look at.
One of the drawbacks, and Jeff, I'm right there with you. I'm not as well versed on this as I probably should be, but I think one of the drawbacks with using rodent models is that terrestrially they're oriented horizontally, and so they don't have as much of a pressure gradient as we do normally. So I would have to get information on whether that amount of tilt is on par with this amount of tilt in humans.
Mm-hmm. Yeah, I know that hind limb unloading has been used to look at cardiovascular effects, but yes, that is the exact question that people have with mice, actually, who have even less of a tilt than rats. Of course, rats aren't humans at all. But that just brought up the final question and last question that I have is, and I'll put you on the spot here, what are some of the combinations of models and paths forward? Is it human studies? Is it animal studies? Is it some nice mix of human animal cell that you see going towards resolving this issue?
Yeah, the easy answer to that is all the above. And I'll put it to you this way. The sample sizes are just so small with the astronauts, as we've all mentioned here, that we need to expand it greatly. We need to include terrestrial models of all sorts, and that could go down to biochemistry. It could be genetics. It could be rodent models, non-human primates. You name it, and also include mathematical models.
Right.
We need to have those as well. In order to chip at this from all different directions, because back in 2011, 2012 was the point where I saw that first manuscript coming out about VIP at the time, and I read it and I was very interested in it, but my initial reaction was, it's NASA, they'll figure it out in 6 months. And here I am, and I'm just, wow, I'm amazed to be here, but here I am now, and we're collecting a lot of data, but we're still not there. So we need help from everybody. And that's one of the reasons why I and Dr. Tarver and all of us here are so excited about being on a program like Red Wrist School to help spread that, to increase awareness and enthusiasm.
Okay, I'm going to stop you because you stole my thunder. But this was a really amazing talk. Thank you so much for coming and doing this talk. And one of the attendees concurs that it's very useful.
Thank you.
Thank you again. Jeff, do you have anything to add?
Just to reiterate, how that was really, Captain Brunstetter, that was an excellent talk. Really appreciate all the insight and answering all those questions. And looking at some of the comments from the attendees, they feel the same way. So thank you very much.